afternoon, everybody. Thank you, Milescape, for giving me this opportunity. So, MS39, a workhorse. Financial disclosures none, but I would like to mention Smith. Where is Smith? People from Milescape who keep on helping us in understanding the machine better. So nowadays is a time that we start combining two technologies. Over here, as Dr. Pooja has already explained, we are combining tomographer with a OCT machine. And this is all what it gives. To start with, this is what standard tomographer will give you, 4 maps. But as you go to the next screen, the fun starts. We know that epithelium does so many things. It's a masking agent. And therefore, it is important that we should be able to look at the stroma without epithelium. So over here, we have got stromal thickness, epithelial thickness, total thickness, as well as stromal elevation. And these are the patients where early form of keratoconus can be diagnosed. Normally, the epithelium looks like this, but these are all the different patterns epithelium can look like. And therefore, it is very important to understand whenever you are doing a treatment like surface treatment, like streamlight, where the epithelium is also removed with laser, whether this patient is a good candidate. For example, on left-hand side, this patient is not at all a good candidate for streamlight, whereas on the right-hand side, yes, we can go ahead with streamlight. Now, epithelium, this is a case of dryness. You can see how angry the epithelium is. And this is definitely, if not treated properly, patient is definitely going to have lot of trouble. Then stromal thickness map, you can see that minimal thickness thing is displays inferotemporally, and it is increased in size. And you can see the stromal elevation, the tongue shape projection, which is coming from the left hand downside into the center, and this is definitely a suspicious case. Keratoconus screening is a very good tool which is available with MS39. On the top, we have got standard maps, anterior surface, posterior surface, and the 3 thicknesses. But on the in the second row, on one side, we have got Gaussian distribution of posterior and anterior, which is basically for comparison of understanding how much the disease is progressing. Whereas the other 3 maps are showing pattern deviation, how much there is deviation from the normal pattern. Same thing holds true for the lower 2 graphs. Along with that, we also have a OCT image here, notable point spread, all the indices, and MTF. So, in one nutshell, on one single screen, you know everything about keratoconus. This is one more example, and you are famous of this Krebs clause, PMD. This is another important screen where you get an understanding of whether the patient is progressing or not. We get as many as 25 points, 25 examinations can be compared, and we can choose which 5 to be compared. You can see that 5 elements are there, and first and the last map, the difference map is there, and it's very easy to understand whether the keratoconus is progressing. Now, this is a case where intact version, you can see on the left-hand side top, there is a sudden drop. That is the day procedure was done. Intact planning. Nowadays, we have, rather than going always by the posterior coronal curvature, sometimes if there is too much of difference with the posterior and anterior axis, we do consider only anterior axis. And this is possible because over here, you can adjust the incision site and placement of the intacts. And this is what the result is, excellent reduction in this thing. Zernike analysis, Dr. Pooja has already discussed, so I'll skip this. But it is very important that we understand what is the aberration profile of the patient, and it also gives you epithelium aberration profile. Now, this is a optical quality summary screen. Again, it's a very, very important screen when we are going for any, refractive surgery, when the patient is very, very demanding, this comes into play. Over here, on the left-hand side below, you have point spread function, then right side is MTF, and on the extreme right below is the actual values of the Zernike polymers. On the top, we have the aberration diagram, then the simulation of the visual chart, and what is the refraction patient is going to take. It is also possible to see the changes with difference in pupils. So, for example, this is a patient who has got a pupil size of 2 millimeters. On the extreme left you can see, and excellent point spread function. But the moment pupil size increases to 6, you can see the point spread function has dropped and coma has appeared. You cannot see the numbers, but from 0.01 it has gone directly to 0.6. So unless and until we are thinking of something like Contura, is not a good candidate for simple refractive surgery. Pupillography has become very important. Nowadays we are getting very old patients for cataract who are interested in trifocal oil and the pupils are very small. And very young patients for cataract 48, 30, their pupils dilate like anything. And therefore it is very important to understand how the pupil is going to play. Even if we say that most of the oils are not pupil dependent, that is not entirely true. Then angle alpha and angle kappa, everybody is aware of what is this? Biometry. This is another fantastic tool which is available in MS39. What we can do is that it will measure everything of the anterior by ray tracing technology. We just have to feed in the axial length and the calculation comes by its own. I'll take half a minute. Okay. So suppose you have a patient who has undergone LASIK and then ectasia and then C3R and then intacs. Then which formula going to use? Whatever you have done, ray tracing formula is always going to work because it is actually measuring the anterior and posterior corneal curvature. I'll go through this fast. OCT images, intacs, ICL vault, retained nucleus piece, DMD, double cut LASIK. There are 2 cuts of LASIK, first aborted, second completed. Epithelial bullae. Thank you.
Thank you very much.